We're starting to get people coming in now. So if you're just joining us, don't forget to sign in the chat box. We'll do name and site in the chat so that because this is a required RN webinar, we want to make sure you get credit for being here. And Vanessa's going to take attendance. So make sure you put your name in there. And then it seems like we're still short a few. We had a couple more people register. So I'm going to wait maybe another minute or two. Usually by like 9:02, everybody arrives. So feel free to get situated and we'll get started in just another minute. All right, so I am going to get us started with some just ground rules and overall just general information, and then I think we'll still have people coming in. So we'll keep letting them in as they join. If you could please, the first request will be to please turn your cameras on if your computer has the ability to have a camera. You guys know when you're doing these visits, it's so much better to talk to a face with somebody nodding and smiling, and then you really feel like you're being listened to versus just a little square. So if your camera has, if your computer has a camera, please turn it on so we can see you. Second, if you're just joining and you didn't hear before, please sign in the chat with your name and your site so that we can make sure you get credit for attending this webinar. And if you get kicked in and out, no problem. We'll keep letting you in. So don't worry about it. If you have to turn your camera off to take care of kids or pets or whatever, we get it. So feel free to go ahead and do that at any point if you need to. And if you're going to step away for any extended amount of time, you can just send me a private message just so that I know. I don't think we'll be calling on anybody, but that way there isn't like a where'd they go kind of thing. So we get it. Stuff's happening. Totally fine. So another little piece, we are recording this and we're going to put this on the Stronger Families blog. So if you have to leave and you're not able to catch the end of it, or you have a lot of additional staff or colleagues that you think might want to watch this, we will put it up in the next week or two. And I will send it to everybody so that you know how to find that recording. And all the resources, all the slides will be on there as well, so that you can go back and watch it again. And then finally, if you have any questions while we're going, you can type those in the chat, and Vanessa Reyes and I will be monitoring the chat box to make sure we're pulling out any questions. And if anything's pressing, we can bring those up to Dr. Ga, and if not, we'll save them for the Q&A. It sounds like we'll have quite a bit of time for questions. I know this is a topic with likely a lot of questions associated, so we'll have time for those at the end. So we'll pull those out and make sure we save them. All right, I think that's it for my ground rules. And just overall, thanks everybody for being here and excited to go through this topic. I know this is a popular, we're getting a lot of questions about this topic. So I think we're lucky to have a speaker here who's going to address all those questions and be able to answer anything that you guys have. So I will introduce our speaker and then we'll go ahead and get started. So hopefully you can see Dr. Ga. She's at the top of my screen. And if not, when she unmutes, you'll be able to see her. So we're lucky enough to have Dr. Stephanie Ga with us. Dr. Gah is an assistant professor in the Division of Maternal Fetal Medicine at the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. She completed her medical degree and her PhD in microbiology and immunology at the Albert Einstein College of Medicine in New York. She completed her residency training in OBGYN at UCSF and her fellowship in maternal fetal medicine at UCLA. Her longstanding interest in global infectious disease and maternal child health, which started from her service as a Peace Corps volunteer in rural Honduras, has led her to her current research in perinatal infections, and it also makes her an excellent speaker for today's webinar. So please join me in welcoming Dr. Stephanie Gah as she presents this webinar, What Should You Know About the COVID-19 Vaccine If You're Pregnant or Breastfeeding? Thank you, Dr. Gah, for being with us today.
Thanks so much, Martha, and thanks so much for the invitation to come and speak today. I really appreciate all the work you guys do with the families to support them during such an important time after they deliver. So thank you. So I was asked to talk a little bit about the COVID-19 vaccines and pregnancy and lactation. Before COVID, what my primary research and clinical interests were in global infections. So I studied malaria and Zika in the laboratory and clinically with collaborations in Uganda and Brazil. But of course, with COVID, all of our jobs, I think, have changed significantly, and my research interests really pivoted, and my group has really been focused on almost 100% COVID for the past year or so. So I have no disclosures to give. So just backing up a little bit, just basic facts on vaccines and pregnancy. We know vaccines are routinely given in pregnancy and in many cases recommended. Some vaccines are given, the majority of vaccines are given to protect the mom, and this would be flu vaccines, which we recommend for every mom, every pregnant person, every mom that is pregnant during the flu season, regardless of gestational age. Pneumococcal vaccines recommended in certain immunocompromised patients. And then hepatitis B is also recommended if they're screened and they're hepatitis B non-immune. One vaccine that we also recommend in every pregnancy is the Tdap vaccine or the pertussis vaccine, and this is to protect the baby. This is recommended to be given in the third trimester between 26 and 36 weeks of gestation. And the goal of this is not to protect the mother and that, adults don't really get severe pertussis illness, but to generate antibodies that are then passed to the baby and protect the newborn baby against whooping cough. Some vaccines are not recommended in pregnancy, and these vaccines contain live attenuated virus. So these are viruses that have been in the laboratory weakened so that they don't cause severe disease, but they are still alive. And the examples of these are the MMR vaccine, the varicella vaccine, yellow fever, smallpox, less common here. But with the COVID-19 vaccines, we'll go through some of the data, but they are newer vaccines so far. And we are now recommending that pregnant and lactating people do get the vaccine. I think to understand why we're recommending them and kind of understand our recommendations for how we decide whether we consider them safe or not, it's important to know what kind of vaccines they are. There's 3 different types of coronavirus vaccines in development. And although there's only 3 approved in the United States right now, there are hundreds that are in various stages of development that may come out over the next few years. All of them, the goal of all of them is to generate an immune response, an antibody response that will protect you against SARS-CoV-2, the virus that causes COVID-19. I'll start with the third one, 3 mRNA, because that's the one that we are most familiar with here in the United States. It's the first one that was approved. And the mRNA vaccines basically take the viral mRNA, which codes for spike protein, which is a protein that's expressed on the outside of the SARS-CoV-2 virus and mediates cell entry and infection. So it takes that mRNA, it packages into, it's packaged into a lipid nanoparticle kind of carrier, and that's basically tricks your body into producing spike protein, which then induces the immune response. Going backwards, the viral vector vaccine, so this would be the Johnson & Johnson vaccine, goes one step back in that it doesn't take the mRNA, but it takes the DNA, so the spike protein gene, puts it into an adenovirus vector that is then gets into your body cells and again tricks your body into producing spike protein, which generates the immune response. The protein-based vaccines or peptide vaccines, none of them are currently approved for clinical use, although some international companies are working on these. I think it'll be coming in the next year or so. Would be where the spike protein or parts of the spike protein is generated in some sort of laboratory cell line and then purified, and the protein itself is injected as a vaccine, usually with some sort of immune adjuvant or something that helps stimulate the immune response, again, to generate an antibody response. So there are, again, many different types of COVID-19 vaccines. The mRNA vaccines by Pfizer and Moderna are the first two that were approved in the United States. They were approved in December of 2020. There are 2 doses. And they both need to be stored at frozen temperatures, the Pfizer at a lower temperature than the Moderna, but still I think this has implications for vaccine deployment, especially in areas where there may not be a cold line. These were the first mRNA vaccines that have been licensed for use in the world. So this is very new technology. The Johnson & Johnson vaccine was approved in the United States in February of 2021, and this uses the viral vector vaccine. The AstraZeneca vaccine that is approved in, I think, over 40 countries, especially the UK is where a lot of the data has been coming out. It has not been approved in the United States yet. But these usually use an adenovirus vector. The Johnson & Johnson specifically is a single dose, and it's stored at refrigerator temperature, which is very convenient for distribution. There has been the Ebola vaccine has been in use, and that also uses a similar technology, the adenovirus vector, and that also has been tested and has some history of being tested in pregnancy and lactation as well. Then there's whole virus vectors, whole virus vaccines, again, where the viruses are inactivated, that are in development. Again, none of these are in wide use, and not in the United States yet. And as I discussed, the protein subunit vaccines or the peptide vaccines are also in development. So to go into a little bit more detail about the mRNA vaccines, because I think these questions come up a lot and there's a lot of, I think, misinformation out there about how these vaccines work. So again, this is the COVID-19 virus or SARS-CoV-2, and the viruses carry mRNA, their genetic material inside. So what we've done is taken the mRNA that codes for the spike protein. We make the mRNA in the lab, you put it inside a lipid nanoparticle kind of carrier molecule, and this helps the vaccine basically get into the cell. So the lipid nanoparticle coating of the vaccine fuses with the lipid bilayer membrane of the cell membrane, and it releases the mRNA into the cell cytoplasm. And then in the cytoplasm of the cell, it uses the cell's natural RNA translation machinery to make the spike protein that is then expressed on the surface of the cell. Your immune system, the B cells and the antigen presenting cells, see the spike protein. They recognize it as foreign and not supposed to be there. And so basically this stimulates the immune system to start generating antibodies, stimulating the T cells also to kind of further amplify the immune response. And this is what makes the mRNA vaccine so effective, actually, where there is both a B cell and a T cell response that helps generate a stronger immune response. Again, there's no live virus, so it's impossible to get infected with SARS-CoV-2 or any other virus from the mRNA vaccines. The adenovirus DNA vaccine, so this again is the Johnson & Johnson and the AstraZeneca virus. So this is where in these vaccines, the SARS-CoV-2 spike gene or the DNA is packaged inside an adenovirus. And adenovirus is the virus that causes the common cold. They've engineered the adenovirus so that it is unable to replicate, in that it can just get into the cell, but it can't make more of itself, right? So it's a way to kind of use the adenovirus to get into a cell, uses its entry mechanisms. And once it gets in, what the adenovirus naturally does is it puts its DNA into the cell nucleus of the cell that it's invading. And from there, the DNA is translated in mRNA. The mRNA is exported into the cytoplasm of the infected cell. And they're kind of same as the mRNA vaccine. The cell's natural machinery takes over to turn this into a protein that is expressed on the cell surface and stimulates the immune response, very similar way. Again, there's no replicating virus. So once the virus kind of gets in, injects its DNA, it's kind of stuck in the cytoplasm of the infected cell and can't replicate or can't cause any disease. But, you know, the problem that we've been having in this, I think when the effectiveness of the vaccines was, the first data came out, I think in late October. And then in December, there actually was I've been in kind of the space for a long time, and I feel like there was a lot more attention turned to pregnancy and lactation than kind of like, for example, in other illnesses. And, you know, there was already a lot of attention in the press about what to do about pregnant and lactating people. And the reason is that the pregnancy and lactation was an exclusion in all the trials. They weren't tested at all. And so there was no data on pregnancy and lactation for the COVID-19 vaccines when they first came out. And there's all these questions about why were they excluded. I think the assumption is to protect them, right? To protect pregnant and lactating women. Pregnant people would not want to take the risk. I think a lot of people assume they wouldn't want to take something where they didn't know what would happen to the baby. But I think there's other reasons why they're excluded. They, including pregnant and lactating people in trials, increases the cost and the complexity of trials. So beyond their normal primary outcomes that they already are looking at, for example, antibody responses, protection against COVID-19. So all the trials so far, the majority have looked at actual clinical illness with COVID-19 as their primary outcome for measuring whether or not it works or not. But of course, if you include pregnancy and lactating people, then you also have to do pregnancy follow-up. And you also have to do neonatal follow-up traditionally for up to 1 year in order to show that there really is no effect on pregnancy. And this, of course, increases the staff that you need, the length of the trial, et cetera. There's also administrative and regulatory disincentives against including pregnant and lactating people. For grants, you have to put in a section of protection of women and children and explain how you're protecting women and children in your trial if you're including these populations. And again, this is kind of more work to do while you're applying for funding in IRB applications for approval of the study. There's a section on inclusion of vulnerable populations if you are including pregnant women or children. And this also, again, includes the administrative burden for including them. So it's much easier just to say, I'm not going to include these people and move on with the trial. The problem is that this approach is actually harmful to a large part of the population. And I think the movement is changing where pregnant and lactating people should actually be included in trials unless exclusion is specifically justified. And the reason is that we know, from that pregnancy is a risk factor for severe disease and complications for many illnesses, H1N1, about 10 years ago. And as we know now for SARS-CoV-2, if you're pregnant, then you have a higher risk of getting severely ill. And of course, many at-risk people are pregnant or lactating. How many, healthcare workers or first essential workers, frontline workers are pregnant or lactating? It's a large part of the population and definitely a large part of the hospital-based population as well. Many of pregnant or lactating people also have medical comorbidities that put them at increased risk of disease, diabetes, obesity, other immune compromised states. Many of them have autoimmune diseases, et cetera. And so excluding pregnant and lactating moms from these trials basically forces them to make a decision without any data. And this is kind of the worst case scenario, right? Because data, especially at the beginning, there was zero data. And data collected outside of a clinical trial is in many ways suboptimal in that it's not systematically collected. The majority, it's not controlled. And they often rely on registries where people volunteer to participate, which introduces bias. Although for, I think, almost every single medication, drug, vaccine that we use at all, they've essentially all the data has been collected in this way, that they've always, pregnant and lactating moms have always been excluded from the actual clinical trials, at least at the beginning. And I think we need to think about protecting pregnant people through research and not from research, and change the way we think about including them in research. So this led to a lot of confusion early on in that the regulatory and advisory committees didn't really know what to say, right? I think, when you're on you work for the WHO, you're on the CDC advisory committee, you want to make recommendations based on evidence, and there really was no evidence, direct evidence at the time. And so in January, when the COVID-19 vaccines were released, the WHO and the CDC actually gave opposing recommendations for whether or not pregnant people should get the vaccine. The WHO recommended, or actually said that pregnant people should not, or are not eligible for the vaccine, should not get it. The UK version of the CDC also said the same thing. But the CDC said that pregnant people should not be excluded or prohibited from getting the vaccine based on pregnancy status. And so I think to summarize the guidance from kind of our major regulatory public health and professional societies, this chart I've kind of tried to go through and keep up, but it's there have been some changes since I first made this slide. So for pregnancy, at the beginning, the UK and the WHO again said that if you were pregnant or lactating, you were not eligible for the vaccine. This caused a huge uproar, and within a week, they kind of changed their guidance, but they didn't actually make it. You had to go back and read what their announcement was, but they changed their guidance to it should not be routinely given, and you can consider it in high-risk situations. For example, if you're a healthcare worker. The US FDA has maintained that you should not be denied access to the vaccine if you are pregnant or lactating. The American College of Obstetricians and Gynecologists, and the Society for Maternal Fetal Medicine have consistently stated that the vaccine should be offered to pregnant people. And just recently, the CDC in April stated that the vaccine should be recommended in pregnancy. And this is based on the new data that just came out a couple of weeks ago, which I'll go through in a second. For lactating moms, it's been the recommendations have been more favorable. Again, the FDA says that we should not deny access. The UK, the WHO, the Academy of Breastfeeding Medicine, and the American College of Obstetricians and Gynecologists all say we should offer to lactating mothers, and the CDC and the Society for Maternal Fetal Medicine do state that it is recommended for lactating individuals. And so the reason for all this anxiety about, should we give the vaccine or not in pregnancy and lactation is, because there was no data, there were a lot of questions, unknowns. The first question, I think, is, efficacy. Do they work? If they don't work, then we don't even need to talk about giving them to pregnant and lactating moms. So we didn't know whether the immune responses were similar in pregnancy versus non-pregnancy, or lactating versus non-lactating. We do know the immune system changes during pregnancy. And so pregnant individuals are a specific population that need kind of targeted study. We don't know, we still don't know whether the duration of the immunity changes with pregnancy. And this is, again, because of the immunocompromised state of pregnancy. We don't know if the level of antibodies is the same and whether it lasts as long as in the non-pregnant population that was extensively studied. And so because of that, we don't know if the dosing amount is appropriate in pregnancy as compared to non-pregnant adults. Should the dosing schedule change? These are all questions that, again, remain to be answered. Number one on people's minds, again, of course, is safety. Are the vaccines safe for mom and baby? What are the immediate side effects of the vaccine in pregnancy? Are you more likely to have serious side effects? Will this affect the baby? Does the vaccine cross the placenta or into breast milk? Does the vaccine cause any placental or fetal inflammatory response? Could this be harmful? And does the vaccine lead to any adverse pregnancy outcomes? Does it increase the risk of miscarriage, stillbirth, birth defects, or other complications? And then on the other side, are there potential benefits? We know that, for example, for the Tdap vaccine, that, the reason we give that vaccine is to benefit the baby, not really for the mom. And so is immunity passed to the baby in utero or through breast milk? We know now that it does. And then is there an optimal timing of vaccination during pregnancy if we were able to choose when to get vaccinated? And so I'm going to go through some of the early data that has been presented. The research has gone very quickly, luckily. And so we do already have some data, even though it's only been about 6 months since the vaccine was released in general. The biggest data, the most important data, I think, has come from the CDC Vsaf registry. And I don't know if, at least here at our vaccination sites at UCSF, when you got your appointment for the vaccine, they were very, very proactive about getting everybody to download the app on their phone so that they could enroll in this registry. So there are 2 components of the Vsaf registry that's relevant for pregnancy. So the main one was to monitor for vaccine-related symptoms and potential side effects for everybody. And so you download this app, and then they basically send you this text message every day for the first week after a dose, and then kind of less often afterwards. And you check off what symptoms you might have. If there's anything that's kind of raises a red flag, they would call and get more information about a potential symptom you might have had. They also adjudicated with medical records when possible. And importantly, one of the questions in that main Vsaf registry was, are you pregnant? If you were pregnant, then a separate pregnancy registry team would contact you to ask for you to enroll in a specific pregnancy registry where there were more questions specifically about the pregnancy itself, how far along you were, any complications, comorbidities you might have. And then with that, they plan to follow you until you gave birth, and for, I think at this point, up to 3 months after delivery. So these findings were just published at the end of April on just their pregnancy, the pregnant population in the Vsaf registry. And actually, I think it was quite an incredible work by the CDC to be able to get this data so quickly. They had, I can't actually even remember the total number of Vsaf registrants they had, but they had 35,000 people that reported that they were pregnant that were included in this report. It was about half and half Pfizer, Moderna, a little bit skewed toward Pfizer, I think, because Pfizer had like probably a week or two head start in getting the vaccine out compared to Mrna. The age distribution is again appropriate for reproductive age of pregnancy, and you can see that they reported whether you were pregnant at the time of first vaccination or if you got pregnant or realized you were pregnant, I should say, after your first vaccine. So again, the majority were pregnant at the time of vaccination, so knew they were pregnant and getting the vaccine. And then about 13% had a positive pregnancy test after they received their first vaccine. One thing to note is that 75% of the participants in this were white. And I think this has to do with this was in the first 11 weeks of vaccine rollout in the United States. So the majority were healthcare workers and not the general population. And so that's kind of important to keep in mind as far as generalizability. I think some of the best data that has come out of this so far is also the symptomatology. So again, with the Vsaf registry, it was an app-based kind of, ping where they would ask what symptoms you were having in a very detailed fashion. And again, because essentially all of these participants were healthcare workers, I think the accuracy of this reporting is probably much higher than the general population. So on the left side, you have the first dose for Pfizer at the top and Moderna at the bottom, and then the second dose on the right. And you can see that almost everybody reported some pain at the injection site. And then the kind of more systemic symptoms, fatigue, headache, myalgia, chills, and fever were also reported. Somewhat higher for Moderna than Pfizer, but I think very similar overall. I think in the dark blue is if you were pregnant, and then in the light blue is if you were not pregnant. And so you can see overall, just looking at the general trends, that if you're pregnant, you tended to report fewer symptoms than if you were non-pregnant. One thing I think was interesting that came out of this data was, the initial Pfizer and Moderna reports on the vaccine reported anywhere from a 10 to 20% rate of what they called systemic or serious side effects, which included fatigue, these ones right here, fatigue, myalgia, chills, and fever. But the actual rate for both of them was higher than initially reported in their original trials. For example, after the second dose of Pfizer, it was about 30 to 40% of participants reported fever, compared to, I think, about 10% in the original trial. And then for the Moderna, the second dose, it was much higher, about 50 to 60% of participants reported a fever, compared to, I think it was about 20% in the original Moderna trials. This paper, we haven't gone into whether, I don't think it was underreporting in the original trials, but it might be that females have more symptoms than males. In the original trials, it was both men and women. And that might be something interesting. And again, in pregnancy, you seem to have fewer report these serious side effects. And then moving on to the pregnancy registry. So again, if you reported that you were pregnant in the main Vsaf registry, they would try to contact you. And I have a few friends that were pregnant and participated in the registry, and they said that the phone interview was actually quite extensive, that it was took 40, 45 minutes, and they asked all these questions about your pregnancy, your reproductive history, and any other medical problems they might have, or medical comorbidities you might have, or complications of pregnancy. So I think the data is very rich. Participants were contacted once per trimester, depending on how far along in pregnancy they were at the time of vaccination, after delivery, and when the infant was 3 months old. And The goal of the pregnancy registry is to get pregnancy specific data. So risk of miscarriage, stillbirth, any pregnancy specific complications, if the mom was admitted to the ICU, adverse birth outcomes, neonatal death, hospitalizations for the baby, and birth defects. And again, so far the plan is to follow the babies for up to 3 months of age. And so, as you can imagine, they have fewer participants in the pregnancy registry than in the main Vsaf registry, but they have about 4,000 people that they've reported here. And I think the last time I looked was about a week ago, that's up to about 6,000. Again, 50-50 for Pfizer and Moderna. And you can see the distribution of gestational age at enrollment. The majority were enrolled in the second and third trimesters, fewer in the first trimester, and they also did have a handful of participants that were enrolled peri-conception. The majority had not reported COVID-19 in pregnancy, but there were some that did report that they had had COVID prior to getting the vaccine. And they don't have a comparison group, right? Because everybody in this registry got the vaccine. So they compared against the published incidence of these birth outcomes or pregnancy outcomes in the general literature. So in the registry participants, about 12% reported a miscarriage or a spontaneous abortion prior to 20 weeks. And this is comparable to the general rate of miscarriage in the United States, which ranges between 10 and 26% in general. There was no significant increase in stillbirth rate. There was one stillbirth, which is again consistent with the general population of reported less than 1%. As far as neonatal outcomes, there was a 9% rate of preterm birth at less than 37 weeks. And again, this is preterm birth for all reasons, either spontaneous or medically indicated, which is consistent with our general rates reported between 8 and 15%. The rate of small for gestational age babies was similar. Rate of congenital anomalies, again, was similar, about 2 to 3%. And there were no neonatal deaths. And this is in the 827 completed pregnancies at the time of publication. So this overall is very reassuring that there were no significant, I think Tony Fauci said, red flags for danger in pregnancy or harm in pregnancy. And there was no no significant spike in miscarriage rate, which you would expect if they got vaccinated in the first trimester. And also kind of no significant increase in preterm birth or other issues that for the majority of the participants that have delivered so far, which were the third trimester. So again, this is still early data, and the major limitations is that this data really is from just the very first 11 weeks of vaccine rollout. So from December through the end of February. These are all early vaccinees again, so they're all healthcare workers and 75% of them are white. So I do think that the population-wide comparisons with, for example, preterm birth may not necessarily be appropriate as kind of the gold standard for what is, for example, the preterm birth rate in the United States is, higher in certain populations than in white healthcare workers. And again, this is just in the first 827 completed pregnancies. So since there wasn't a significant increase in preterm birth or miscarriage rate, these are mostly third trimester vaccinations. But again, this is very reassuring overall in that it's the largest study to date. I think the symptomatology data is excellent. And I actually can't imagine that anybody would have a bigger sample size than 36,000 for for reporting of the side effects of the vaccine. Again, the data was collected prospectively and very rigorously. And for the registry, there were very detailed phone interviews and medical record adjudication as well. And they are continuing to collect data. So
Do you know where this is going?
Yeah, I do.
So I can ring you up.
We do need to wait for data from kind of the second trimester and the first trimester infections that have yet to deliver, luckily, because there wasn't kind of the significant bump in early deliveries. And so I think moving on a little bit about there's the Vsaf data, and then we also want to know whether the data works. Whether the vaccine works, and whether or not there is an antibody response that is protective in pregnant and lactating individuals. And this is some of the early data from a study that I'm running out of UCSF called the COVID-PAL study, which is COVID-19 vaccines in pregnancy and lactation. Right after the vaccine rollout, there was a huge kind of interest in, again, stemming from the first vaccinees, which are healthcare workers. A bunch of people emailed me and, are you studying the vaccine? Can I participate? I'm getting the vaccine, I'm pregnant, there's no data, I want to contribute. And so we had, I think at some point I was getting like 5 to 10 emails a day from people all over the country asking if they could donate their blood or milk to a study to study the vaccine because they were getting it and didn't, wanted to contribute. So it's really, really amazing, actually. We've enrolled about 150 participants so far in this trial, or not trial, this cohort study, to determine whether the immune responses are similar. And kind of in our initial data, we do see that immune responses are generated after the vaccine and are very similar to non-pregnant female controls. So in the red, you see the pregnancy group, purple is the lactating group, and the blue is the non-pregnant female controls. The first group is pre-vaccine. The second group is after the first dose, and then it's the last group of bars is after 4 weeks after the second dose. And this was actually pretty split evenly between Pfizer and Moderna, 50-50. You can see that the IgM response, which is usually the first antibody response, is induced after the first dose and stays pretty steady, but it's the IgG response that is the most robust and is the biggest determinant of longer lasting immunity and neutralizing capability. And so you can see that there is a significant increase in IgG response after dose 1. But there were a few people in the pregnancy group that did not generate a significant, a positive IgG response, which is indicated by this dotted line, until after the second dose. So the second dose is very important to get everybody at protective antibody levels. We've also looked at our patients that have delivered. About 15 have delivered so far, for which we have data. And we also, again, do see this dotted line right here is the cutoff for having antibodies or not. The majority of our moms did have antibodies that were also present in the cord blood, so they did pass the antibodies to their babies. There's one participant who did not have antibodies at the time of delivery, and of note, she only got her first dose about 10 days before delivery. So it's important in order, the mom needs to get all their antibodies generated in order to be able to pass to the baby. Other groups across the country have also reported similar findings. These are different reports looking at kind of different subsets. This one out of Boston showed that there was an antibody response similar to what we found after the vaccine. And in this study, I think they only had 8 participants that had delivered at that time. And again, they found antibodies in cord blood. This study out of Chicago found that, I think they looked at about, I can't remember, maybe 20 or 30 cord blood samples after delivery, and found that the majority, again, did have antibody. Majority of cord blood did have antibodies if their mom got the vaccine during pregnancy. And again, that the vaccination needed to happen at least 2 to 3 weeks before delivery in order to transfer to the baby. And again, similarly here in this study out of New York. And in lactating people, there have been fewer studies. This study came out, this really nice study was just published in JAMA as a letter, I think a couple weeks ago. This came out of Israel, and they followed about 80 participants that were breastfeeding at the time of vaccination. This is only in Pfizer. They only had Pfizer in Israel. But they did show that there were significant levels of IgG and IgA in breast milk that were induced over time. So you can see here for IgA, after the before the first vaccine dose, there was no IgA that was specific for COVID-19 as expected. There was a little bit after the first dose. This is when they got the second dose. And you can see the IgA levels really increased after the second booster dose of the Pfizer vaccine. IgG levels are also present again, really after the second dose. So this, again, kind of reinforces the importance of getting both doses of the Pfizer or the Moderna as prescribed. Our group has looked at whether or not the vaccine mRNA components are detectable in human milk. We tested, I think it's 7 participants donated lots of samples of milk at varying time points after getting their vaccine doses. We had to come up with a special kind of PCR assay to detect vaccine-related mRNA because its sequence is a little bit different than the natural spike mRNA, the natural mRNA sequence for spike in the virus. And we were not able to find the vaccine in any of the milk components in the fatty layer of the milk or in the milk supernatant. So this is reassuring, and it's hopefully will be published soon. A lot of people have been talking or asking about if the Pfizer trial. So Pfizer has launched a double-blind randomized controlled trial of their goal is 4,000 pregnancies to test their vaccine specifically in pregnant women. This is an international study that with about 60 sites in the United States. They are enrolling women or pregnant people between 24 and 34 weeks of gestation. And they're going to be blinded. I think that's really really important to note that half will not get the vaccine and get a fake vaccine. And the other half will get the vaccine, and they will be followed through delivery. The participants will be unblinded at delivery, and if you did not get the vaccine, you're given the opportunity to get the vaccine, and they're going to follow the moms and the infants for 1 year of age. There's a lot of blood draws throughout the study to look for antibody response, and again, their primary outcome is they're going to look for clinical COVID-19 disease. They started this trial in March 2021, so I would expect results probably in winter of 2021. So the end of this year, I would expect the earliest results to be available as they're vaccinating, and then they have to kind of wait for the pregnancy to finish. And to be honest, I think it might be hard for them to recruit for this trial in the United States, at least, because the vaccine is available to all pregnant people. And I think in all of the United States at this point, I mean, in California, starting March 15th, I think was the first date that anybody that was pregnant could get the vaccine if they wanted it. So I imagine it'd be difficult for them to enroll people that would be willing to be randomized, in that they have a 50% chance of not getting the vaccine. But we'll see. And so I guess in summary, how do you consider the risks and benefits of the vaccine or not in pregnancy and lactation? On the left, these are the reasons you should get the vaccine. Pregnancy and lactation is a risk factor for severe disease. We know that if you're pregnant, you're more likely to be in the ICU, more likely to deliver preterm from complications, from respiratory complications, et cetera. The vaccine works in pregnancy and lactation based on early antibody data. Data in the non-pregnant population, which we think probably translates to the pregnant population, shows that if you're vaccinated, you do reduce transmission to your friends and family, which will reduce the risk for your immediate circle and your community. You can pass the immunity onto your baby, which will protect the newborn baby. And this is in utero and through breast milk. And I think this, could potentially be really important in that there is unlikely to be a vaccine for infants for quite some time. And that early safety data indicates that overall it's safe. And again, we do need to wait for kind of complete data for pregnancy, but there are no there's no significant concern at this point. The reasons to not get the vaccine is if you have no risk of getting COVID-19. I would say this is probably almost nobody, unless you are completely sequestered and quarantined with no risk of exposure. If you're allergic to one of the vaccine components, and we have not seen any reports of any serious allergies to the vaccine in a significant way, or if you want to wait for more data. And again, this is a very personal decision. That is to be respected, that you do want more data before getting the vaccine. But I do think that for the majority, we are recommending that we get the vaccine. Everybody that I see, I recommend to get the vaccine, in that I think it's really important to protect yourself first, as a pregnant person. That's the best way to protect your baby in utero, and also to protect your newborn baby and your family after delivery as well. So that's all I had prepared, and I'm happy to take any questions that anyone might have.
Thank you, Dr. Goff, for going through all of that. Really informative, and I think everybody appreciates just having that information and the science behind all of it. So we have one question in the chat, and then I'll read that out, and I will also encourage people to unmute themselves and ask questions or continue to type in the chat. I also have some from when you all registered that we can go through too. So we'll start with the one that's in the chat from Jody. It says, are they doing any studies if you received the vaccine prior to pregnancy and now they are pregnant? So if you got the vaccine first and now you're pregnant.
They aren't doing studies specifically, but in both the Pfizer and the Mrna original trials, about 25 people, I think, got pregnant or not by accident, I shouldn't say. Like, they got pregnant even after they enrolled in the trial, even though they were instructed, they were tested before getting the first shot and they were negative, and they got pregnant afterwards. And so there's a little bit of data there. The CDC registry is also following anybody that kind of became pregnant over the course of the vaccine dosing. And so we'll have some data there. And I imagine some other groups around the country are probably also studying those. There's a lot of questions about whether the vaccination impacts fertility. And it does not. Basically got started through this terrible rumor that somebody posted on a blog online and totally amplified. But there's no evidence that it affects fertility at all. As you can see, people got pregnant, whether on purpose or not, after getting the first dose. And the American ASRM, American Society for Reproductive Medicine, which is kind of the reproductive infertility professional society, does recommend getting the vaccine. If you're getting fertility treatments, they do recommend certain breaks in getting the vaccine, just not because they think it's harmful, but because if you do have some of these side effects that seem to be more prevalent than originally reported, they don't want that to get in the way of your cycle and interfere with your cycle when you're kind of going through all the hormonal treatments. So there's a little bit of timing, but they are definitely recommending it.
Is there a difference in immunity between whether you get the vaccine during pregnancy or lactation? Meaning, will the baby receive more immunity if the mom gets the vaccine while breastfeeding or in pregnancy?
Yeah, that's a great question. So I think if you're, again, the goal of vaccinating is not to protect the baby. I think it's like a side benefit. The goal of vaccination is really to protect the mom. When you get vaccinated during pregnancy, the mom's antibodies in her blood are transferred to the baby and show up in the baby's blood, right? And that's transferred through the placenta. So the baby will be born with antibodies that last usually about 4 to 9 months, on average 6 months. It depends on the antibody. And so that will protect the baby through the first few months of life. Through breast milk, you get different antibodies. You don't get antibody in the blood, right? Not to a significant degree anyways. You get IgA and IgG is secreted into the breast milk. And these types of IgGs are, these types of antibodies are, IgA is really important for what we call mucosal immunity. So what it does, it kind of forms this protective kind of film, is the way I think about it, on mucosal surfaces. So in the mouth, throughout the gut, and if it recognizes any viruses or any badness, it'll bind it before it can get, taken up into the body through the digestive system. IgG is similar. It doesn't coat as well, but it's also kind of floating around and moving through the digestive system. And if it recognizes anything, it'll bind it. And we call it neutralizing, where it basically binds the parts that it needs to get into a cell and infect. So in that way, it's kind of one of the first barriers to infection. So that's another way that the baby can be protected through that mucosal immunity that you don't get if you're not breastfeeding, right? Or you're not getting breast milk, I should say. So I think, if you're vaccinated just during lactation, the baby will not have antibodies in their blood. And I didn't show today, but we've tested some babies from our cohort where the moms were vaccinated during breastfeeding. They don't have antibodies in their blood, but they do have antibodies in their stool, which is kind of cool. Like, it passed through. And they do have antibodies in their saliva as well. So, but not in their blood. So I think a combination of two, and I think the two are very important. If you think about, COVID-19, it does get in first through the mucosal surfaces, right? You breathe it in, babies are, breathe in through their, take in stuff through their mouth. So I think it's really important that mucosal immunity protects the newborn baby. Does that answer your question? I think it was kind of roundabout. So like, if you want both, you want blood protection, antibody protection, and the breast milk protection, you get vaccinated before delivery, ideally at least a month before delivery, to ensure transfer of antibodies. But there is still benefit. There's definitely benefit in getting vaccinated after. And also, I should note, if you get vaccinated before delivery during pregnancy, you also still make antibodies in your breast milk. So you kind of get the double benefit.
So if a mom receives the vaccine while she's lactating, will the baby receive the same immunity for 6 months as they would during?
No, that's different. So they don't have blood circulating antibodies. They just have the antibodies in their digestive system. And so it really is while they're breastfeeding. And I think there have actually been surprisingly few studies on this, but I think that it probably also depends on how much milk they're taking in. As the babies grow, they're breastfeeding less often. And as they start taking solids as well, less breast milk. So I think that level of immune protection from breast milk probably just naturally goes down as they're taking in less milk as they grow.
I've got a couple in the chat I can read out. One asks if there's been any studies on women who got COVID during pregnancy to check on their antibodies and how it affected the fetus and the newborn. So not the vaccine, but the actual COVID disease.
Yeah, that's a great question. So my group and some other groups have also been following, cohorts of pregnant people that got COVID during pregnancy. They also have an antibody response that is passed to the baby. Interestingly, the numbers of antibodies are lower than for the vaccine, like the overall numbers, but the neutralizing capacity of the antibodies is a little bit different, and neutralizing capacity is, you know, you can have lots of antibodies, but they may not all work the same way to prevent the virus from infecting. And so the neutralizing function of natural infection versus vaccine-induced immunity is different. And we're still kind of working out the details of why. Either way, you know, and also I will say not everybody with natural infection has significant antibody levels as well. It's not as consistent as with the vaccines, and we don't know exactly why.
Okay, I've got another in the chat. This was a private message to me, so you can't see this one. But it says, do we know when studies will be done on Moderna and when it passes into the breast milk? So it sounds like the Pfizer one might be the only study out there right now, and we're curious about that. And then how much immunity does the baby have with only the first dose versus both doses? So if a client doesn't follow through with their second dose, is there still benefit? Or if, you know, the timing is that they only get the first dose?
Right. So yeah, we have some, my group has some data on both the Pfizer and the Moderna. They're very similar. It's not published yet, so it's, I didn't prepare it. I'm happy to share. But basically there is an antibody response with both Pfizer and Moderna. Again, similar to what the Israeli group showed with the Pfizer vaccine that has been published. You really need that second dose to get a really good response. There's a little bit of an IgA response, but the IgA and IgG really need that second dose to get the booster response. And so again, I would encourage everybody to get that second dose for the breast milk antibodies and also for the mom's antibodies as well. You can see, like, you know, there is a response after the first dose, but it's much stronger after the second dose and likely much more sustained. Because you also don't want the immunity to wear off after 3 months, right? You want to make those shots count. And so we know, I think right now that the antibodies, at least from the early, I think Pfizer data on non-pregnant people, it's, you know, after 6 months, they're still good, the antibody levels. And we'll kind of see how long they last overall. But we do want to, with vaccinations, there's the first dose is usually called the prime and the subsequent doses are the boosts. And so you kind of rev up your immune system. There's some activity, but it's really that second dose that basically tells your immune system this is a real thing and you really need to crank it up and make these antibodies for reals because this is a real threat. And so that's why the second dose is so much more effective in generating a robust response.
That's really helpful. And that makes sense why I think some of the reactions for the second dose are stronger too. So I've got another one that is another private chat, so you won't be able to see it, but it says, do you think that the vaccine will be offered to infants and children like other scheduled immunizations? Although infants and children are excluded, will this be something that's offered in the future?
I don't know. I'm somewhat skeptical. I don't think it will for a long time. I think, you know, they just approved Pfizer for 12-year-olds, but it's because Pfizer, you know, kind of, I'm annoyed with all of them because I feel like they started these trials, you know, they started them like a year ago, right? Like last summer. And then they had the early data in October, but kind of like as they were kind of going through the data, they started these other subgroups earlier. So the 12-year-olds were started before before the adult data came out. So that's why kind of they're like in line, but they didn't even start the pregnant people until March, like a year later. I feel like they should have started them much earlier. Anyways, I don't think that they've started any infant trials yet. So I do think it'll be a while before they are officially approved. But I think I heard, and I don't know the details, that there's some, like a Chinese group, one of the other vaccine trials internationally is studying it in infants and children. But I don't know if that will be available here in the United States.
Okay, that's helpful. Then we got another couple, they're coming in now. So you're stimulating a lot of thought. This is good. What if the second dose is missed at the 21 or 28 days? Is there still utility in getting it, the second dose at a later time, or is it just basically after you've reached that 28 days, it's no longer effective?
No, the recommendation is to get the second dose as soon as you can. I know there was some like vaccine pipeline issues maybe a month ago where people weren't able to get their second dose on time because the shipments didn't arrive. And you know, the 21 and the 28 days is just what they decided to do in the main trial. I know there's a lot of sub trials that both companies have been doing, looking at different dosing schedules and regimens, and all the information we have is that the second dose is important to get it as soon as possible. You try to target that, but it's likely still effective even if it's later.
Okay, that's helpful. We got another one about, I think this will be helpful for counseling some of the families that are RN served. So they're asking about, because we know that antibodies are present in breast milk and we know that the breast milk changes over time to meet the baby's needs, are there any changes that the mom might expect to see in her breast milk? So like changes in color, consistency, anything like that, that the vaccine might be causing?
That's a great question. So we've been serving the moms that have been getting the vaccine, and nobody's noted any changes yet. I think a lot of people are worried that their supply might go down or their baby might be fussy, like if it would taste different, and they haven't noticed anything. You know, again, my study is a small sample size. I think it's about 50 people that have been reporting on their symptoms, but nothing kind of uniform and nothing striking.
And then another about the pediatric dosing. So for 12 to 15-year-olds, is the dose amount the same as you see in adults and follow the same like 2-dose schedule, or are there any changes for how they're dosing the younger kids?
Oh, I think it's the same dose. I haven't looked in detail, but I think it's the same. And that's just the Pfizer is the only one so far that's been approved for 12 down to 12-year-olds.
That's all I have in the chat right now. So I'll see if anybody, I'll pause for a second, see if anybody has ones they'd like to unmute and share. Oh, we just get another one in. So I'll give you a second. Anybody want to unmute and ask a question directly?
I'm not sure if you covered this, but so is it expected that you'll need to get a booster annually for this vaccine?
That's what they're speculating. I think nobody knows. You know, I was a total vaccine skeptic. Like if you'd asked me like a year ago, I'd be like, there's no way they're gonna get a vaccine. There's only 5 vaccines in the whole world, and scientists spend like years and years trying to get them to work. So I was very happy to be wrong about that they were able to get this COVID-19 vaccine out so quickly and that it works so well. But again, we still don't know how long it works, right? Like they started giving it last summer. We don't know if the immunity for the vaccine is going to last a year or 2 years. We have no idea. We also do know that there are variants, and the variant strains of SARS-CoV-2 are quite significant, right? Like there's probably 5 strains that are circulating now that have so far been covered by the vaccines, but it's mutating pretty quickly. And so it's also possible that in another year, the circulating strains will not be covered by the vaccines or not as well. And in that sense, you might need a booster, or it might be like a seasonal shot, like the flu shot, where, you know, every year or 2, you need one to cover the circulating strains. And that's all kind of unknown. I think it's incredible that we've come so far with, you know, this, it's really been 18 months that we've even known this virus has existed, and there's already vaccines where millions of people across the world have been vaccinated. Of course, you know, we're definitely not out of the woods yet, but you know, the science and what we know about the virus has been changing so quickly, it's impossible to know. I would be prepared for that, though. I think especially the newer strains are so much more infectious, it seems like. And at some point, you know, viruses always outsmart us, and there will be one virus that will be, you know, break through the vaccine, and then that one will become the main circulating vaccine or circulating virus at some point.
Okay, we have a couple questions, 2 different people asked, so I think it's a pressing question about changes to menstrual periods. So has anybody reported any changes like before or after the vaccine, or in like the months after delivery related to the vaccine?
Yeah, I think this is kind of a big unknown. I know maybe a month ago, somebody reported that they had crazy periods after, and I think there's a couple studies that have been launched just to survey it. It was not reported in the original studies. I'm not sure, and the problem with, I don't understand, I guess, a lot of us are skeptical because we can't think of how the virus would change, or sorry, the vaccine would change your menstrual cycle, like what the link would be biologically. That being said, I think that there are, we're learning things all the time, and it's possible. You can't ever say it's impossible. But menstrual cycle changes are also really hard to study in that a lot of things affect it, like stress, and kind of like a lot of outside factors will affect the change in menstrual cycle. And it's also somewhat subjective. It's hard to objectively measure flow. So I think it's a very difficult thing to study through a survey, which is kind of all that's been happening, all that we have so far that I know of.
All right, so I'm going up in the chat now for another one. So this one's about the side effects of the second dose. So when a mom has the side effects, the kind of severe side effects, or maybe even mild, does that cause the baby to react in a similar way? And then if so, what is the best way to combat that? Or are there any kind of complications that clients should be worried about?
I think the thing that we would worry most about is a fever. High fevers and prolonged fevers in pregnancy can be harmful to the baby, or actually probably just cause stress in the baby. That we haven't really seen that with the vaccines. Like, people report fevers, but they haven't been like very high, and they haven't lasted more than a day or two. And for the majority of patients, they've come down after Tylenol. So I think, as far as vaccine related fevers causing significant harm to the baby, very unlikely. If you do get fevers, we recommend taking Tylenol to bring down the fever. And the harm to the baby really is kind of like, when you're not feeling well, the baby in utero probably is also feeling not so great too. But it's transient. Babies recover really well. We see when you're sick with COVID, you have really high fevers for a long time, and that's much, much worse. And so, balancing the risks and benefits, I definitely would not, every person has their personal or their individual reasons for why they would decline a vaccine or not get it. But I think fear of the fever is probably not a good reason, in that you can treat the fever. And depending on your risk for getting COVID, the fevers and the inflammation related to getting the disease is much worse than a day or two of this inflammatory reaction from the vaccine. And I see a chat. Yes, I think some providers are recommending they take Tylenol before the vaccine. We don't recommend ibuprofen during pregnancy, but postpartum, it's great. I don't recommend before, just because I feel like you don't really know if you need it. But if you want to, it's fine. But I think when you start to feel sick, it's definitely safe to take Tylenol during pregnancy, and then after pregnancy, ibuprofen. I think there was another question about how soon after delivery is it safe for moms to get the shot? Anytime after delivery at one of our hospitals, we're giving it to everybody that's postpartum. If they want it, they're getting the Johnson & Johnson, single shot. And, or they're, I've had postpartum moms get scheduled for their vaccine shot as they walk out of the hospital. They go to the vaccine clinic before they go home. So there's no kind of waiting period after you deliver. Again, I think when you're thinking about getting it during pregnancy or not, it is an individual decision. Medically, I would, I think everything weighs towards getting the vaccine as soon as you can get it at any stage in pregnancy. Number one, again, to protect the mom, right? That, you know, the most important thing for a healthy pregnancy is a healthy mom. And I think that's always kind of what you want to emphasize to your patients. And the added benefit of, you know, immunity transferred to the newborn baby, who is unlikely to, you know, have a vaccine anytime soon. And protect your family as well, other members of the family. You know, I think there's been a lot of stuff about, you know, children don't get sick and it's okay. And it's true. Children and infants don't seem to get as sick to the similar degree as adults, you know, especially older adults or adults with comorbidities. But I will say, you know, some of my colleagues that are pediatric infectious disease doctors, as the prevalence of COVID has gone up in the population, those rare complications you still see. And I've had, you know, I think every single pediatric hospital has at least a couple children that are really sick with COVID. We've had a couple newborn or infants, I should say. I don't know how, I think one was maybe 3 weeks old but anyways, we've had a few infants that were very ill as well. It's rare, you know, it's less common, but it still does happen. So I think as a community and, you know, as far as reassuring parents about doing everything they can to protect their families is important.
I've got one that came in as a private message. I think it kind of fits with that, and maybe some of these rare cases, or, you know, maybe not, but it's a question about if there's been any information or studies done on pregnant moms who are diagnosed with COVID and then carried the baby to term, but then the baby ended up dying. And this is the person who asked because this did actually happen to somebody they know. So she's curious if that's a trend or if that might be related, etc.
Did that baby die of COVID or something else?
I don't know, maybe she can send me the chat and let me know. Yeah.
You know, we know that vertical transmission or transmission of SARS-CoV-2 to the baby in utero is possible. We also know that it's very rare. I think, you know, multiple groups, including mine, we've looked for evidence of infection in hundreds of babies that were born with moms that were infected with SARS. We haven't really found it. That's not to say that it can't happen. There are case reports. I think in the literature, there's probably 3 convincing cases where the baby has been infected. We've taken care of a couple babies that at UCSF, I know that probably were infected, but it's kind of hard to prove because it's always hard to catch the, you know, the PCR positivity in a baby, as well as, you know, kind of figuring out the timing because, you know, obviously there's the prenatal transmission, there's the perinatal transmission kind of during the process of delivery. And then there's kind of, you know, the mom's taking care of the baby or their family members are taking care of the baby. It's very close and intimate. So it's hard to tell when the transmission occurred. But we do know that, you know, newborn babies can get sick. I don't know of any cases where the mom had documented COVID early in pregnancy and kind of recovered, and then the baby was sick way at the end. We have one case that we suspect there was something COVID related. We just can't prove it, where the mom was really sick around 26 weeks. And the baby was born at term, but very ill for unclear reasons. We couldn't ever figure out why. Because, you know, for all of the reasons the baby should have been fine. It was born at 39 weeks, but like didn't feed well, had really bad diarrhea. Like we couldn't figure out what was wrong. So, and the only thing was that the mom was really sick with COVID in the early 3rd trimester. So I think at this point, we're still learning a lot. You know, it's still a really new disease. And so I think, yeah, it's hard to say, but we know that it's not common, I think is the main thing. If it were very common, we would have seen a lot more of it.
Okay, and I have one more that hasn't been answered. So this last one asks about pregnant women or women taking birth control who are already have a risk of blood clots. If there's been any studies about the Johnson & Johnson vaccine and pregnant women due to this risk of blood clots, or just any information about. I think that's a topic that a lot of people are worried about.
Yeah, I think the Johnson-Johnson clot risking is really interesting. On one hand, it's a really rare blood clot that they found, which, you know, in the brain, which is really unusual. But also on the other hand, they've given millions and millions of doses and there were like 5 cases. So it's kind of like a less than 1 million chance. But again, they've only seen that with the Johnson & Johnson and the related AstraZeneca as well. So my suspicion, and this is just me, is that there's probably something about that virus, that the adenovirus vector in certain populations, like in special people, that might increase the risk of clot risk. Otherwise, you kind of see it across the board. But we don't know what it is, and it's very rare, I think, is the bottom line. So, you know, millions of women on birth control, millions of women that are pregnant have gotten the vaccine and have not had those issues. It's like a less than 1 million chance of having that serious blood clot. And so I don't think it's a reason to not get it if you're at risk for COVID, because your risk of getting COVID is probably much higher. But I think if you have, I guess I would advise my patients, if you have a known clotting disorder, right? And you had the choice, I would probably choose to get the other one if you have the choice.
I think that's interesting. And I had a couple of people send this in a question, but I also wanted to ask you if you've touched on this quite a bit with the idea of kind of weighing the risks and the benefits. And I'm wondering if you have any advice for our RNs who see families in the community who don't have a medical background. Like, how do you have that conversation with them? What are some of the, if you've had luck with that, what are some of the key things that you can say or kind of talk to them about to get kind of assuage some of that fear with the clients?
Yeah, I think, you know, I think COVID's turned into this thing where like there's so much information and misinformation and fear, and it's so, everything's happened so quickly. I think there is a lot of natural apprehension about these new interventions, but I would kind of, you know, take a step back and say, you know, did your patients get the flu shot, right? Like, would they get the flu shot? Do they get the flu shot every year, and why? You know, because you know that when you get the flu, you get really sick, and pregnant people, like, they died. Like, I took care of a couple of patients that died 10 years ago with H1N1, otherwise perfectly healthy. And so, you know, that there's that very real risk of very serious illness with these very hypothetical risks, or, you know, hypothetical risks for the vaccine that have not been proven and are very unlikely. Like, you know, as a scientist, you can never say like never, ever, ever, but like, you know, we think about all the different pathways and now millions of people across the world have gotten these vaccines, and there have not been significant bumps in birth defects. We would have seen them by now, honestly. I think, you know, the first trimester vaccines, they all would have gotten their second trimester anatomy ultrasound by now. And if there were any red flags, it would have been reported at some point if there was a significant bump in heart defects, for example, or something. You know, we've kind of moved past those critical time points in pregnancy. And so I think, you know, there's a lot of fear and I think a lot of mom guilt because you don't want to ever do anything that could potentially harm your family or, you know, your baby. But what I tell my patients, you know, regardless, not even COVID, like if they're diabetic, you know, or, you know, they have, you know, high blood pressure, like taking your medications is the most important thing you can do to your baby, you know, or for your baby. You know, staying healthy is the most important thing you can do for your baby, because the COVID moms that I've taken care of, you know, in the ICU, like their babies are not happy for sure. And, and not even just their baby in utero, but their family. It's like a huge, thing for their family. They have other children. So I think for the health of their family, we know that COVID is really bad. And we've all, taken care of patients that have gotten really sick or have family members that have gotten really sick or died from it. And so I think that the reality of that is important to bring to patients against these theoretical risks that may be possible, but, we take risks all the time. You cross the street, there's like a 1 in a million chance that you're gonna like get hit by a car, right? Or something. But we do these things because we know we have to, and it's part of kind of moving forward and living. I don't know if that resonates, or if anybody else has any, has any advice or thoughts about how they've spoken to the patients that they've taken care of.
Yeah, I think that's really helpful, and just a good way to, I think the flu, particularly the flu vaccine, is a good piece for, there was a lot of hesitancy at the beginning of whenever we were pushing flu vaccine, and we've made it as far as we have, where a lot of people get it every year. So talking to the families and comparing it to that and saying, well, did you take that? And then asking why and hearing their stories first is a great strategy. So I think that sounds good. And I did put in the chat too, if other people have strategies that have worked, if you've talked to families about this, and or what hasn't worked, if you push too hard on a family, or you said something that didn't resonate, like share it in the chat, or feel free to share it with us, unmute yourself so that your other RN colleagues can learn from your experiences too. Because it's great to have all this information from you, Dr. Gahn. I think as long as it's so helpful for us to hear it, but then we forget that we also then have to translate it to others and talk to them about it too. So people have ideas, feel free to share.
Yeah, and especially, I don't know, I imagine a lot of you guys work in, the high risk communities, like, Latinx communities or Black communities, where, I think also thinking about the local prevalence of illness and kind of their risk, they're living in, their communities have a higher risk. So it's almost more important for them than like, some of my patients like work remotely all the time, and sadly never see anybody. And so their risks are probably lower than, if they're kind of living in, more crowded living situations, and or their job makes they're forced to go out and interact with people, where the risks of contracting the illness are higher, and the costs, I think, as well. Are they able to miss work because they're sick, right? The costs are much higher for certain populations than others, and I think that's something else to take into account as well.
All right. I know we have quite a few still remaining questions, but we're kind of low on our time. So I just want a final question for you, which is an interesting kind of different path here. If we have families who are interested in participating in the clinical studies or trials, is there somewhere we can direct those moms to so that they can add to this information bank that we're getting?
Yeah, so there's a few different, I wish there was a central lab. My study, it's really just for San Francisco, people that live in San Francisco. I think the CDC Vsaf registry is really important for everybody to participate in if you get the vaccine and you can. A colleague of mine, Dr. Asadu, she's a family nurse who does research on infant feeding and breastfeeding. She's actually running a study on infant feeding experiences during COVID-19, and a component of that is also a lot of interviews and survey based on, whether you've noted any changes or difficulties with infant feeding in general during COVID. She has a study that's recruiting nationally. And I'm sure there are many others that, yeah, I'm not sure about in LA County specifically for the vaccine.
Yeah, we can look into it too, but I think even just having this information and showing how important all of the the studies are might help, if you can share that with your clients, might help them be more willing to, if they're approached at the hospital, to say yes, or at least do the Vsaf registry, because that is, I haven't seen all that data that came out of that, but that's so great to know that I don't know if any of you have done it, but all you do is just answer a couple of questions every once in a while, and it's really not that taxing. And it's so cool to see all the data come out of that. So that's hopefully at least something we can use as to remind people of the importance of doing those things. So, all right. Well, I know we're. Oh, thanks. Vanessa put in a couple of registry information. So thank you, Vanessa. She's always got the resources for us. So you can click on that and we'll put it in the resources for the webinar recording as well, and make sure everybody gets that. So I know we're at our time, but I know we could probably keep asking you questions for the whole rest of the day. This has been so helpful. Really, really appreciate the amount of time that you left for questions and were able to give us all this information, and the presentation was excellent. So let's all give Dr. Ga a round of applause and a big thank you for being here with us today.
Thanks so much. Thank you for all the work you do. I remember when I had my first baby, I was like that nurse that came to my house. Like, thank you so much. And I wish everybody had this resource that you guys give. It's really important. Thanks so much.
Thank you. That's really sweet. All right. Thanks everybody for being here. We will put the recording up on the blog. I will send everybody that recording when it's processed so that you can watch it again and again if you need to, share it with whoever you want. And then we also have an evaluation, which I will email out, and we'll make sure those results get to Dr. Goss so that she can see your comments and hear from you directly. So thank you everybody for being here. Thank you, Dr. Goss, for your time. Really appreciate it. Thanks everybody. Have a nice day.